Good afternoon. Welcome to Medical Grand Rounds. I'm Bob Walker, Chair of the department. Really pleased today to have Juan Nguyen, who is an associate professor and now chief of the Division of Hospital Medicine at Zuckerberg San Francisco General. Juan went to UCLA for her bachelor's degree, got her MD from UCSD, did her residency at Texas Southwestern, came to UCSF for a fellowship. We lost her for a little while where she went back to Texas to University of Texas Southwestern at Parkland, but then managed to lure her back to join our faculty, and she's risen beautifully as a really major figure in hospital medicine and in epidemiology, and particularly with an emphasis on social determinants of health. She's also deputy editor, in addition to being the chief of the Division of Hospital Medicine at the county. She's also deputy editor of the Journal of Hospital Medicine, and director of hospital care of the UCSF Prize Center program. Her research focuses on social and structural determinants of health delivery and outcomes for patients from historically underserved populations, and what we can do to make that better. Obviously, an incredibly important issue, and one that's in the news these days as we think about the current state of politics. She's a recipient of the Society of Hospital Medicine's Outstanding Junior Investigator Award, has won the Junior Investigator Award from the county, and was a 2022 Chan Zuckerberg BioHub investigator. The title of her talk is More Money, Fewer Problems, examining the relationship between guaranteed income and housing stability.
Thank you, Bob, for the kind introduction. And I do just have to call you out a little bit, because the title of the talk is actually More Money, Less Problems. I understand the grammatical correction, but you're clearly not a fan of 90s hip hop. So my disclosures are I've received funding from the Chan Zuckerberg BioHub to support research related to this presentation, and I have no other relevant financial relationships to disclose. So our roadmap for today's talk, first, I'll get into a little bit about why guaranteed income. How did I get into this field to begin with? Second, I'll talk about the evidence base for guaranteed income and housing stability. And third, I'll talk a little bit more about what we're doing now in terms of the current study I have on guaranteed income and housing stability. So why guaranteed income? Let me just go ahead and address the elephant in the room. Why is a hospital medicine physician and health services researcher studying cash and housing? And I will spare you my wrapping, but to borrow a line, I'll tell you how I became a doc who studies cash and housing affairs. If you know, you know. So how did I get into this area? Well, one of my career core guiding principles is that everyone deserves outstanding care no matter their circumstances. And so I've spent the majority of my career practicing in safety net settings as a hospital medicine physician, first at Parkland Hospital in Dallas and now at San Francisco General. And when you're in the safety net, it's pretty much impossible to ignore the structural context of illness. And my clinical experience in the safety net really shaped my research interests and portfolio focused on understanding and addressing unmet health-related social needs. So I'm going to briefly take you through a few areas of study to show you how I ended up with cash and guaranteed income and housing stability. In general, my research area of interest is on understanding and addressing social needs to improve care. So the first area, social factors predict readmission risk. What feels like a million years ago, we did a series of EHR-based 30-day readmission prediction models for common hospital conditions. And this was a series of studies that used clinically granular EPIC data on over 30,000 hospitalizations in North Texas that were linked to a regional all-payer claims database. And the big picture findings are that adding social factors to our models added predictive value beyond clinical factors only. So we found that things like income, payer, marital status, and housing stability as measured through address changes predicted readmission risk. That being said, as a mentor of mine once said, if it predicts, meaning a factor doesn't have to be causal or even clinically meaningful to be useful in a prediction model. So this next group of studies examined, do patients think social needs actually matter to health? And if they do, what are the needs that matter most? So this first study was a qualitative focus study of 55 community dwelling adults who received food assistance. And what we found was that there was no clear pattern of dominant or actionable social needs. And in fact, financial strain or poverty was the core issue with no obvious single potential intervention. So this is an example quote from a participant who said, "Every month, almost nothing is left, and I have to make miracles with what is left. Sometimes all I have left is $40, and there's 6 of us, and I have to buy food and other basic things. My kid has asthma, and all the inhalers are very expensive. So what can we do?" So this next study pivoted to hospitalized patients, the hypothesis being that maybe in the context of a specific acute illness, that a hospital patient might have more specific needs than their community dwelling counterpart. So this was a qualitative study with semi-structured one-on-one interviews of 38 patients hospitalized at San Francisco General with congestive heart failure. And again, we found that there was no clear pattern of dominant social needs, no like single need or even group of needs. And additionally, we found among participants, there was no expectation of help from the hospital for social needs. So this participant said, "The bottom line is it's all up to me. No matter how much information they give me or how many programs I've been to, the final decision is mine anyway. It's the hospital's responsibility to help me get better, but as far as stuff outside of here, that's all on me." And also, we found that there was a lot of ambivalence about social needs screening among patients. So this participant said, "I could talk about anything that's concerning the emergency that I'm here in the hospital for, but I wouldn't want to go off track talking about something else that's not pertaining to why I'm here. For example, I wouldn't want to talk to the eye doctor about something personal that's going on in my life." So this really resonated with me, particularly as a researcher, because for me, it highlighted what we call social needs in the field are what other people call personal issues that they don't necessarily want to share with their physicians or clinical teams. So this group of studies got me thinking, when there is no single common social need, how do you design an intervention that addresses many needs and meets patients where they are? So this is when we started thinking about cash. So why cash? Shockingly, it is a uniquely patient-centered intervention for diverse social needs. And specifically, the characteristics that make it a very ideal intervention are: first, it's flexible, so it addresses different needs for different people. It's fungible, meaning it allows patients to control and shift their resources as their priorities change. Third, it's respectful, meaning you don't have to necessarily have people disclose specific and sensitive needs in order to say, you know what, maybe you need some cash to help you through this difficult time right now. Third, it's efficient, less administrative burden. You don't have to necessarily have a whole program set up to assess eligibility and deliver a complex, multifaceted intervention. And then third, finally, it's timely, meaning you can give cash and deliver support when it's most needed rather than suffering through an administrative delay. And why housing stability? In the series of studies I presented to you, we actually deliberately excluded homelessness in that work because it felt like something that was too big to tackle. It is clearly a social need, but what was a health system or a hospital going to do to meaningfully address homelessness? That being said, as a safety net hospital medicine doctor, it is impossible to ignore the role of housing stability in medical care because it affects everything. If you've been in the hospital, you know it affects adherence, it affects people's ability to follow up, it affects people's ability to perform self-care once they leave the hospital. And so when an opportunity emerged to assess the role of guaranteed income on housing stability, I said, yes, sign me up. But first, what's the evidence say? So this takes us to the second part of our talk. What do we actually know about guaranteed income and housing stability? So I just want to go through some definitions first. Guaranteed income is a form of what we call unconditional cash transfer, which is cash that is given with no conditions or strings attached. It's also sometimes called direct cash transfer. So unconditional cash transfers generally come in two flavors. One is called universal basic income, and the other is guaranteed income. And you may have heard both of these terms in the lay press. So universal basic income is the idea that you should give everybody a sum of money unconditionally, regardless of need. So if you're Oprah, you just say, you get $30,000 and you get $30,000 and you get $30,000. And the idea behind universal basic income is that it could potentially replace existing social programs. So instead of giving people Medicaid, CalFresh, CalWorks, you would just give them some sum of money every year to try to help meet all those needs. So this is an idea that was popularized not in this past, but the previous presidential election by Andrew Yang, who talked a lot about the freedom dividend. Guaranteed income, in contrast, is the idea that you should give cash, but to prioritized high need groups. And the idea behind guaranteed income is that you're trying to supplement existing income and social supports. And just to make things confusing, sometimes people will call this GBI, guaranteed basic income, and you'll hear basic income and guaranteed income sort of intermixed, but they are actually supposed to be two separate but related concepts. So what is the state of the evidence so far in terms of guaranteed income studies? So there's growing interest in guaranteed income as a tool for financial stability and well-being. Prior to 2018, the work was primarily done in lower and middle income countries, but since 2018, there's now about over 150 pilots in the United States. There are several projects locally. You may have heard some of these names: the Abundant Birth Project, Miracle Money, Black Equity Economic Empowerment Movement, and the Bay Area Thriving Families Study. So the early findings out of some of these studies are that there are some modest improvements in mental health and potentially financial security, but there are actually very, very few rigorous studies that are focused on housing stability and homelessness. In fact, there are only two, and those are the two we'll talk about today. First is the New Leaf Project, which was done in Vancouver, and the second is the Denver Basic Income Project. So the New Leaf study was done in Vancouver and from 2017 to 2018. It was published about a year and a half ago in the Proceedings of the National Academies of Sciences, and it has this very splashy title: Unconditional Cash Transfers Reduce Homelessness. And the press also jumped on the study. I was covered in the Washington Post, and there's a lot said about how cash transfers reduce homelessness. It really felt like a miracle treatment. So to take a closer look, so the New Leaf study was a cluster randomized RCT of 120 recently homeless individuals that were residing in shelters in Vancouver. There were 65 people in the control group and 55 in the intervention group. And what the intervention was people got 7,500 Canadian dollars in one lump sum, and they were followed up for a year after receiving that lump sum. The primary outcome was nights spent homeless. In other words, nights spent in a shelter over 12 months. So these are their main findings: shelter nights in the prior 3 months. I said that the follow-up was 12 months, but they stopped here at 6 months, and we'll get back to that. But the overall headline findings were that the intervention group had 99 fewer nights in shelters collectively across the group at 1 year. Some of the key limitations: there's actually a very large loss to follow-up at 12 months. So they don't show this in the figure, but here's the life table of how many people actually were in the study at 12 months. They lost almost about 50% in both the control and the intervention groups. Second, at each of the interval time points, so the 3, 6, and 9 month time points, there's a significant amount of missing data. So anywhere in the order of 22 to 51% missing data. And then going back to the last point I made, this graph here stops at 6 months, and you can see that the two graphs really converge at 6 months. So my interpretation of the study is that a one-time lump sum cash transfer initially reduces shelter nights in the first 3 months, but both groups actually have similarly fewer nights in shelters by 6 months. The second study in this area is called the Denver Basic Income Project. This was conducted from 2022 to 2023, and they recently released their report of early findings last summer. And similarly, it got a lot of great press. Within their own report, they said, "We have groundbreaking findings. All groups showed significant improvements in housing." And CBS News also said significant improvements in housing outcomes. And I was like, wait, we're doing an RCT. We got to catch up. But let's take a closer look. So this was a mixed methods RCT of cash assistance for 1 year. They enrolled 807 participants, and they randomized people into 3 groups. There was an active control group where people received $50 a month for 12 months. There was a monthly payment group where people got $1,000 a month for 12 months. And then there was the lump sum group that got an upfront payment of $6,500, followed by $500 a month for the remaining 11 months. So even though this was billed as an RCT, research participation was actually voluntary. So people were randomized to the control and 2 intervention groups, but then they were invited to participate in research after they were randomized, and they did not have to consent to participating in research in order to receive the payments. So of the 807 participants, 93% consented, but only 78% actually completed a baseline survey. And the primary outcome in the study was the proportion of people with stable housing at 1 year. So these are their main findings. And the top line finding that I saw in a lot of press releases was that 45 participants had stable housing at 1 year. And so if you look across all three groups, the proportion of people with stable housing is about 43 to 48%. They don't show the statistics here, but the difference is not statistically significant, nor is it really clinically meaningfully different. Some limitations of the study, very strong healthy volunteer bias, meaning the people who volunteered to participate in research probably different than the people that didn't. These are usually the people who are the most altruistic, put together people because they're showing up to a research study. And similarly, like the New Leaf study, there was extremely high loss to follow-up. About only 51% of the total 807 participants were still in the study at 1 year. If you kind of reduce the denominator and say, well, let's just look at the people who did the baseline study, they still had about 33 to 41% loss to follow-up at the end of 1 year. So my conclusion from my reading of the study is that housing is improved, but it's across all groups, including the control group. So yes, housing was significantly improved among study participants, but that's probably not because of the effect of the intervention, since housing improved across the groups, whether or not you received a meaningful sum of cash. So to recap the state of the evidence, there are many robust evaluations of guaranteed income underway, but very few on housing. There are high attrition rates that really limit the internal validity of our existing studies. And in fact, even with those biases, neither of the two existing studies show like a slam dunk clear benefit of guaranteed income. And then lastly, there are no studies focused on family homelessness. So that takes us to what are we doing in this space right now? So a rare opportunity emerged to co-design a guaranteed income study with community partners that was focused on family homelessness. So this was a collaboration and opportunity through the Benioff Homelessness and Housing Initiative led by my mentor, Margot Kuchel. And I had the opportunity to design and lead the study to assess the effectiveness of guaranteed income on homelessness. So these are our community partners, Destination Home, the Si Se Puede Collective in Santa Clara County, Sacred Heart Community Service, as well as the County of Santa Clara Office of Supportive Housing, as well as the Chan Zuckerberg BioHub. So the overview of the project, it's a 5-year, $6 million project. I received funding from the Chan Zuckerberg BioHub Investigator Award, which is a $1 million 5-year award. It's an award that funds bold, high risk, and innovative research. And yes, they typically fund biomedical work. So our study will be the third major RCT of guaranteed income and homelessness, and it is the only RCT that's specifically focused on family homelessness. So our research question for this study is, what is the effectiveness of guaranteed income on housing stability, health, and well-being among families experiencing homelessness in Santa Clara County? And as a kind of secondary objective, we also wanted to know, are hybrid versus periodic payment strategies preferred or more helpful for families? And we'll get into what I mean by that in just a sec. In terms of our study design, this is a community-partnered, mixed method, single-blinded RCT of 300 families experiencing homelessness in Santa Clara County. Our intervention group is 150 families who receive basically a total of $24,000 over 2 years, and they are allowed to self-select from one of two payment schedules. One is the monthly or periodic payments where people get just $1,000 a month for 12 months. And then at the beginning of year 2 of follow-up, we allow people to say, do you want to continue in that payment schedule, or do you want to switch to the other payment plan? The hybrid or lump sum payment schedule is where we give people $6,500 up front and then $500 a month for 11 months. And again, at the beginning of year 2 of follow-up, they can either opt to stay in that payment strategy or switch to the other one. Our primary outcome is days experiencing homelessness over 24 months. And unlike the other two RCTs, our outcome ascertainment is blinded. For our data sources, we conduct structured surveys every 6 months with our participants. We conduct brief check-ins every month, and all of these are interviewer administered, meaning our staff actually get on the phone and call people every month to see how they're doing. We're conducting qualitative interviews of a subgroup of participants at 12 and 24 months, and we're supplementing this data collection with administrative data sets from the County of Santa Clara, which includes data from their homelessness management information system to give us data on shelter use and housing assistance. We're also getting data on social service use from the California statewide automated welfare system, which is administered through the Social Services Administration of Santa Clara County. And then lastly, we're getting health system claims data from Valley Medical Center. So our progress to date, we started enrolling in December of 2022. We finished enrolling last April, which I'm very proud of. And our participants were initially referred from our partner institutions. So we had 662 households that were referred from the community, and our study team conducted screening, assessed eligibility, and consented participants. Ultimately, we had 306 participants who completed a baseline survey, and the baseline survey was done before randomization. And so we ended up with 153 people in the control group and 153 people in the intervention group. And then you can see it very tiny down here, 3 people from the intervention group eventually declined to enroll in guaranteed income for a variety of reasons. So that group has 150, and we've had some early withdrawals in the control group. In terms of our baseline characteristics, I highlighted a few characteristics. So first, our cohort is overwhelmingly female, female heads of household at 82%. Also, overwhelmingly people who identify as being of Hispanic or Latina ancestry, with about 88% overall. 60% of people have Spanish as their primary preferred language. And then the median monthly income for these households is about $2,200 a month. So when we give them $1,000 a month, we're augmenting their monthly income by about 50%. So at baseline, we asked everyone before they were randomized what their preferred payment schedule would be. And actually 2/3 of people said they'd prefer monthly payments of $1,000 a month. But when push came to shove and people were randomized to the intervention group and they had to pick a payment schedule, it actually flip-flopped the other way. 2/3 of people instead changed their minds and said, I want that lump sum up front of $6,500. And kind of strange. So why the lump sum payments? So some of our preliminary qualitative findings suggest that people were thinking very strategically about the amounts, and they really perceived the lump sum payments as allowing them to make investments that would help set them up for their future long term. So some of the things people thought about spending, did end up spending the money on, were buying a car to get their kids to school, to work for DoorDash, Uber, or it's just to get to work in general. A couple of folks talked about how the lump sum really allowed them to get a security deposit first and last month's rent in order to move to a new place. Several people finished associate's and bachelor's degrees with the lump sum because it was an augmented source of income aside from student financial aid. And then lastly, because of our population, many people actually talked about using the funds to start their immigration process by employing a lawyer, which I didn't know until I did this study. It's about $6,500 to get an immigration lawyer. So some of our early implementation successes. First, trust and engagement from our community partners. This all sounds rosy, fine and dandy now, but I will say at the outset, when we started designing the study, our partners essentially said, you want to do what? You want to randomize and experiment on our community members? Over my dead body. It really took me by surprise as a researcher, because from my perspective, I'm like, if you have a limited sample size and you want to do a rigorous evaluation, randomization is the way to go. And it took us a long time to really kind of align our priorities with that of our community partners and say, hey, like if you want to generate evidence for meaningful advocacy or to understand if this really helps families, this is the most just and fair way to disperse guaranteed income to these families, because you don't have enough to give guaranteed income to every family in your community that needs it. So after that initial, overcoming that initial reluctance, they've actually been fantastic partners who've been involved at every step of the study, including co-designing the study, being involved in designing the evaluation, and then implementing the study overall. Other successes, mostly smooth disbursement of cash payments. So a few of the things we had to overcome, the most meaningful one was participant mistrust in banking institutions. So if you sign up people for a debit card, an online payment system, or even direct deposit, the Know Your Customer federal banking laws require that you verify people's identity through asking for their social security number or an ITIN number, which is sort of the foreign equivalent of a social security. And you can imagine this was before January 2025, but still a lot of people were very reluctant to hand over that information. And so what we ultimately decided on was a two-pronged strategy for dispersing payments. We allowed people to either select from direct deposit or actually go to one of our community partners in person every month to pick up a cashier's check. And we actually right now, I think our disbursement is about 2/3 direct deposit and 1/3 cashier's check. Initially, it was about half and half. So we've cultivated some increased trust over time. And then lastly, we've had very strong participant engagement and retention. Right now, our median follow-up is about 18 months. And at this point, we have about 80% of our original participants still in the study, which is very high, especially in the context of the other two studies that I've shared with you. And I think some of the secret sauce here is that our team, first, bicultural, bilingual, which I listed last, but I think that is huge. These are all, the team is almost entirely Latino women who speak Spanish fluently, with about half the team from San Jose, Santa Clara County. And so when participants speak with them, they feel like these are not, foreign researchers from the university. In fact, most of the time they think from USF. They think we're from USF, but Catholicism is very strong in the community. But they really feel a connection to our study team. These are not foreign people. They feel like the study team is one of them. And so I think they share a lot of things with us that they might not otherwise share. The other things we do, or I mentioned, we do monthly check-ins by phone. If people just pick up the phone and say hi to us, they get $5 a month in gift cards. And then about a year into the study, we switched to having an active control group. We couldn't afford to give everyone $50 a month like the Denver Basic Income Study did, but we did introduce a modest quarterly stipend of about $50 every 3 months. Some of the challenges, so this is going to sound funny, disbursement of research incentives, meaning the gift cards, the $50 gift cards we use to give people for their surveys, the $5 gift cards for check-ins, those are harder to procure and get to people than the $1,000 payments, even the $6,500 payment that we get to people. And that is true for a variety of reasons I will not get into here, but mostly related to regulatory requirements at the UCSF level for procuring research incentives for participants. Our retention has been fantastic, but since the inauguration in January 2025, we've seen a lot of anxiety from our participants, particularly around immigration enforcement. And so people have been really preoccupied with their external environment and circumstances. And so we're starting to see decreased study engagement, even among people who had previously picked up our calls and were happy to talk to us. And then last year, funding. But this is true for every study at UCSF. Right now, we're currently funded primarily through philanthropy for a total of a 2-year follow-up for evaluation, and we are working on securing additional funding to extend our evaluation to look at long-term effects. Some of the biggest surprises, I will name 2. First is that many of our participants actually told us, in contrary to our concern about survey burden, people actually really like being involved in the studies. And they tell us actually it's among the few times when they have time to reflect on like how they're doing in general, what their circumstances are like. And a few people actually say it's sort of like therapy, talking about what's going on in their lives out loud. And so I was surprised that actually doing the surveys in and of themselves, as well as motivations about wanting to give voice to their community, as well as helping other families like their own families, are really the primary motivators for participation. Even though people are very low income, the study incentives that we give are appreciated, but really not the primary motivator for people to participate. And then the second, even bigger surprise is that we've built capacity for our community partners to lead rigorous program evaluations. meaning the same partners that said no randomization over my dead body are now the local experts in Santa Clara County for anyone else that wants to do a guaranteed income evaluation. And in fact, at the county level, they're conducting an additional 4, I think now 5 pilots of guaranteed income in different populations. And our partners at Destination Home are the unofficial consultants. And at a talk I went to a few weeks ago, every single study was like, of course we're doing an RCT study design with a control group. And I'm like, wait, what? Something has changed here. But I'm actually really pleased to see that, you know, we've not only overcome that hurdle, but actually created capacity for research in the community. So in terms of our next steps, completing our data collection through next spring, we're working on gathering our claims data for our various secondary outcomes. And then in December, we submitted an R01 called Assessing the Long-Term Effects of Guaranteed Income on Housing Stability and Health Outcomes in Families Experiencing Homelessness. This is to the National Institute of Nursing Research, and we shall see what happens. This is the Guaranteed Income Study Team. I want to shout out to Celeste, Daliana, JD, Sasha, Jessica, Giselle. I see Diego in the audience. Because these are the people that actually, I get to stand here in front of you and talk about this great work. These are the people that make it happen from day to day. And also a special shout out to Margot Couchel for giving me the opportunity through BHHI to lead the study. That is all I have for you today.
Thank you, Anna. So you stay up here. We got plenty of time. Start with the theory of the case, which is that some entity is going to be coming up with the dollars to do this. Is the theory that those are tax dollars, or is the theory that you ultimately prove that health outcomes are improved and you need to go to the ER less often if you get the support, and therefore the source might maybe originally began as tax dollars, but might be a health plan that is covering the people enrolled and says, by giving these people $5,000 or $10,000 a year, I can save $20,000 because they don't need as much medical care. So particularly for you doing this work as a medical researcher, I'm sure there was some healthcare orientation, although most of the outcomes you're looking at are not really healthcare.
I'm going to take the last part first, which is health outcomes. We do have health outcomes embedded in our evaluation. So we're looking at physical health using the SF-12, mental health using the Kessler-6. We're also looking at healthcare utilization in our cohort. So some health outcomes, even though it's not primarily focused on that. In terms of what does guaranteed income look like? Who's funding this and for how long and for whom? I think that's, you know, the reason there are so many studies, and that's why we're doing the study. I think there is right now not a clear consensus within the guaranteed income community of, you know, do we believe that everyone should just get cash assistance to some minimum level of living? I don't think that's a politically popular stance right now for a variety of reasons. So in the short term, probably not tax dollars. I think there's other places that guaranteed income could be extremely helpful. For example, as a form of emergency assistance to tide people over in short-term crises. So when I was thinking of this as a health services researcher, for me, the sweet spot in terms of healthcare would be, could you give people a sum of money at the time they leave the hospital to set up, you know, whatever services they need? The qualitative study of hospitalized patients, the social needs people described were wanting to have a place to exercise, somebody to do their chores, someone to help them cook, someone to help them do laundry. We have IHSS, in-home supportive services. That takes people weeks to months to get set up. They have to go home while they're sick, interview people, try to hire someone to get all that set up. But if you gave somebody, you know, $1,000 and they could say to their neighbor, hey, can you just come over and I'll pay you? That might be kind of a bridge to getting better while those things are setting up. And similarly, I think in a social services context, it might be, hey, you got a Section 8 voucher for housing, but those take 18 to 24 months before most people are able to find housing that accepts it. So maybe the role is more as a bridge rather than as a permanent support, but all speculation. I think more to come when some of these studies come to fruition.
I assume maybe part of Yang's presidential campaign, there are surveys out there of what the population thinks about giving money to people. Obviously, it's pretty easy to caricaturize this. I'm giving someone a blank check and who knows what they're spending it on. And all you need is some iconic case of someone spending it on something that you wouldn't favor. And you say, you know, why are they spending it on that? So do we know anything about public attitudes about all of these kinds of programs?
Yes, it depends on how you frame it. So the New Leaf study actually had a sub-study embedded in it with which basically gave the public different scenarios saying, well, a homeless person is just going to get cash versus a person struggling with housing stability needs, cash assistance to get back on their feet. And so what their sub-study found was how you frame the question matters a lot. There have been several studies that have specifically looked at spending patterns. How do people use guaranteed income when you give it? So the Denver Basic Income Study tracked people spending via debit cards. The Stockton Economic Empowerment Demonstration, or the SEED project, also looked at spending. The New Leaf study specifically surveyed people in self-reported spending on what they called temptation goods, so sex, drugs, and alcohol. And across all the studies that have collected spending data, it turns out people don't spend their money on things you don't think they should be spending on, whatever that means. In fact, most people primarily use the money for rent, food, and transportation, as you might expect.
It sounded like you were surprised that people went for the upfront money, whereas I would have thought economists would tell you that people value money in their pocket over the promise of even more money later on. How did you sort of square that, and why were you surprised?
Because we had qualitative comments that I didn't show. When we asked people what their preferences are, we said, not only what is your preference, but why? So when people said they wanted the monthly payments, most people talked about feeling like they wanted that stability from month to month. They wanted to know that at a baseline, they were going to have that $1,000 of income coming in every month. And then when we looked at our early qualitative findings, what people in fact said was, well, something came up. One, an unexpected expense came up, but two, the other thing was when people had time to think about it, they felt like the $1,000 a month was just something they would spend away in little amounts over time very quickly, versus having a larger sum to make a upfront investment felt like just a bigger opportunity to invest in themselves.
That's, economists call that revealed preferences, that you figured out what they really want by seeing what they actually did. Let me throw one or two more and then I'll open it up. In terms of the health outcomes, sounds like you're just tracking what happened at their county hospital. Be like doing this in San Francisco and looking only at what happened when people came to the county. Whereas we know that their health, they might have come to the Moffitt ER, might have come to many other hospitals. Sort of, I assume that was just limitations on resources that you could do that. But how did you reconcile the fact that you may be missing a fair amount of health utilization?
We probably are, and I think that is just a limitation of the study. The median age of our participants is 38, and many people are uninsured and avoid seeking healthcare. So I think the best we could do was to surmise if people were going to seek care, it would be most likely at the public hospital system. We're also supplementing this with data from the county level about Medicaid enrollment, although I expect it will be less than half based on some survey findings.
Maybe my last question, then we'll open it. Obviously, the world has somewhat changed since January 20th. So how do you think about this as your research pathway and this line of work in the current environment, which is obviously different?
One, we're not going to call it guaranteed income.
Okay.
What
are you calling it?
A freedom dividend,
oh.
Self-sufficiency dividend. I think that's an open question. I think there's a lot of uncertainty at the federal level and at the state level. I think probably moving forward with this work, the idea would be more to pivot to direct cash transfers or unconditional cash transfers for very clearly defined periods of time. I think that is more politically tenable. The other ways in which guaranteed income has been studied is in the form of earned income tax credits, which is essentially guaranteed income. You get a check in the mail for $1,000. Those are also, so there's, I think, other ways of framing the same work, as well as kind of thinking strategically about where are places that could potentially help.
Great. Open it up and see if anybody here has a question. Yeah. Let me get the mic out. Yeah.
Is it on? Okay. Hello, Dr. Nguyen.
Hello, Dr. Zhang.
When you were showing the demographics, you mentioned how the study population is very predominantly Hispanic or Latina. I was just curious, even on a qualitative level, when you parse through the remaining 15% that is non-Hispanic, has your team noticed any differences in regards to like perceptions or like I or differences in regards to how they've gone about the guaranteed income process, or like whether it's difficulty with, or whether it's easier or more difficult to follow up or anything like that?
No difference between our predominantly Latina participants and others. I will say maybe slight differences in how people use the guaranteed income. Many of the people who are of Latina or Hispanic origin are in families with mixed documentation status. And so depending on their own documentation status, that can limit their employment opportunities. So one theme that's maybe a little bit more specific to that population is using guaranteed income to invest in entrepreneurship. So people will use the money, start up a crocheting business, start up a business where they like do nails and hair in the home, or start up a food cart. Whereas I think families who do not have the same issues with immigration status might be more focused on doing things like spending the money on, employment training and other types of career opportunities. So all around employment, but like in slightly different flavors.
Let's get you the mic.
Thank you for the talk. Dong Lee from the ID. I wonder if there's any outcome differences on people based on the cause of the homelessness. Somebody who has a substance abuse and become homeless versus like mental illness versus homeless and etc.
Yeah, I didn't mention it, but severe substance use and severe alcohol use disorder were exclusion criteria for our study. We had 0 people self-report either. We do include 2 sort of subgroups of people experiencing somewhat different forms of homelessness. About half are people who are literally homeless, living in their cars or don't have a roof over their heads. The other half are people who are at imminent risk of becoming homelessness because they are staying in a place that's either not meant for human habitation, they don't have a lease, or it's a little bit dodgy, the circumstances under which they're renting a place. So they can literally be kicked out at any time. And we, in fact, have had participants who have reported that. But I don't know if the outcomes will be different. We have pre-planned subgroup analyses, so more to come in about 1.5 years. Circle back to me.
Thank you so much for this presentation. This is great, and really great to see it fleshed out a little bit more. One of the things that you brought up was kind of this mistrust of financial institutions. And one of the things that seems like is coming out of guaranteed income studies is folks and their interactions with the credit system, and how that's also a barrier to housing, for example, with like rental applications. Have you seen folks, over participating in the study, has that changed the way they interact with banking, financial institutions, or the way that they're able to kind of function in this economy?
Now, that's a great question. I think maybe the one concrete observation is we've had a few more people shift to direct deposit, but otherwise in terms of interacting with financial institutions, I'm not sure. I'd say in terms of interacting with the housing system, we've had some participants use the guaranteed income to augment their reported monthly income so that they're a bit better able to qualify for certain types of housing. I'd say the other sort of observation about how changes in behavior in terms of interacting with institutions relates more to social services. And I don't know if it's a change in interaction, but maybe for people, there's a shift in perception, particularly for the people who are in the intervention group and have received the guaranteed income. One of the things they talk about is that they are so relieved that when we told them they were getting money, we basically just started giving them money. There was no 6-month re-eligibility determination, no need to recertify your income, your eligibility. And in fact, some of our qualitative interviews, people have these really heart-wrenching studies about somebody coming, determining that they were not eligible for the previous 2 years of CalFresh that they had received, and then having to pay back thousands of dollars of benefits, and then just feeling like it was so undignified and so inhumane that the way they were treated. So that might be like the one institutional observation, but I don't know how systematic that is.
You mentioned that UBI basically says universal, and you had Oprah giving out the checks. Does Oprah get a check under UBI?
She would, actually. She would. And Elon Musk would too, in addition to all his other billions.
You can see how that could easily diminish political support for such a thing. Any other questions here? Yeah. You can shout it out. Go ahead.
Thank you, Doctor, for the talk and also for the 90s hip hop reference. But I wanted to ask, when you did the qualitative interviews or the feedback sessions, did the participants say anything about in terms of getting housing, that receiving the amount of money may not have been enough to obtain housing and then making other decisions with the money as a result, particularly in Santa Clara County? I was thinking about that.
Yeah, I'd say people weren't, the cash was given without any directives about people having to spend it on housing. And so people were free to spend it how they wanted to spend it. People were very cost conscious, as you might expect. Like, I mean, people know what things cost down to the dollar in terms of, you know, how much it costs for gas, rent, car maintenance. So I don't know that people said, you know, this money is not enough for me to spend on housing. I think for most of our participants, there was a very much a forward orientation of, well, what can I use this money for? Not what is this money not enough for? So I'd say, like, people would think about what are the things that would help them. Most people thought a lot more about kind of long-term investments, like, can I use this money for, you know, childcare so I can not work, you know, 3 shifts every day and spend more time with my kids? Can I use this to get my work permit instead of renting out an Uber Eats or DoorDash account, which I didn't know was a thing? Can I switch jobs because now I have a little bit of a cushion so I can be without work for a couple of weeks while I look for something better? So not a ton of specific to housing. We had maybe a handful of participants who did report moving out of the Bay Area because of the cost of housing was lower. And some of it was supported by, you know, the guaranteed income payments. But again, this is a handful of participants in our qualitative study. So more to come on that.
Anything online?
Yeah, there was one online, which I'll paraphrase, which was essentially, if you had to boil it down to if there's, you know, strong evidence one way or the other related to GI essentially and health outcomes. I mean, obviously that's kind of what you're looking at with your study, but kind of what's the state of the research so far on that? Do we have anything?
State of the research on guaranteed and health outcomes. There are a couple studies in developing and low income countries, but they're framing, these are studies from economists. So their framing of, for example, health utilization outcomes is quite different than in health services research. In health services research, oftentimes we conceive of acute care utilization as a failure. People are not cared for in the outpatient setting, but in developing countries, being able to access services is a positive. So in the few studies that there's actually an increase in healthcare utilization. More recently, there was a big study in the 1970s in Manitoba, Canada, which was a cluster randomized RCT where they gave a couple of towns guaranteed income for, I think, 1.5 years, and then followed health outcomes. That is the only other study I know of that demonstrated a meaningful impact on health outcomes. Primarily, people used the hospital less, and they had somewhat better mental health. And then the program was shut down when there was a change in their federal administration.
It sounds like it's fair to say at this, the first question I asked you really is, if it's not coming from tax dollars, you can imagine a world where a large health plan is getting a per capita yearly payment to take care of someone who's very poor, an older person who's very poor under Medicare Advantage, and would be musing about would it be worth us paying this patient some money if I came to believe that I would save enough on the back end because they don't need the ER quite as often, and whether and how that's getting mediated because it improves their housing or improves their overall mental health or whatever it is, that somehow there's a return on investment to do this thing that's not natural for a health plan to give someone money or give someone a rebate. It sounds like the evidence base that would connect those two things, that money spent in UBI or income of some portion, some type, would yield lower utilization and therefore potentially be cost savings in net. Is the evidence base is not there to say that. Is that fair?
I'd say that's fair. There's not a lot of guaranteed income studies in the healthcare space or health systems. I think the other challenges are we don't actually know how much is the ideal amount. Almost all the studies give something like $500 to $1,000 a month in the US, and that's driven in large part by IRS gift tax regulations. If you get something like over $15,000 a month, You have to pay taxes on it. Also, the
A
amount you,
month or a year?
sorry, a year.
15,000 a month.
15,000 a month is not bad. 15,000 a year. And additionally, when you give people these payments, they're considered gifts, but for some social service programs, they are still taken into account when people are applying for eligibility for programs. And so most of the pilots have gotten around that by getting specific waivers from some programs to say, like, we're not going to count this guaranteed income. But I think to do like a really meaningful study of like, does guaranteed income help? I think we need to look at amounts, varied duration, and then, you know, different circumstances and experiences, because right now it's usually 500 or 1,000 for a year, and that's not actually that much money to make a huge difference in the long term.
Yeah, great. Any last questions? Fabulous. Thank you so much. That was great.